Hello, everybody. Welcome back to yet another episode of the Rising Stars in Ophthalmology. Today, we're going to touch upon a very special topic, one where it's very close to most of our hearts, if I'm not wrong, emerging trends in ophthalmology. And we all want to know about this. So we got the best plethora of experts here to talk to us about it. Well, before we go ahead, I would like to introduce what the Rising Star series is. It's a 9-episode series which basically surrounds us around one rising star, or shall I say risen in this case, Rahul, and surrounding them with 3 celebrity panelists. Now, let me tell you, the celebrities we talk about are not the ones that are followed by paparazzis. They are the ones that really are the real heroes in the field of ophthalmology from where we stand. This is an interactive discussion, so any audience member watching can please throw out their questions into the panel or the chat window of both YouTube as well as the website. We're live on risingeyestars.com and on our YouTube channel, Rising Stars in Ophthalmology. Obviously, being a global event, this is going to be watched time and again. And we also have our reruns on our website, risingeyestars.com. Please watch out for our social media, Facebook, Twitter, LinkedIn, Instagram, so that you can get a lot of the educational tips and snippets from all the episodes, season 1 and 2. I'd like to thank you personally for tuning in and thank the sponsors to make this happen. And now to do the honors, I'd like to call about one of my favorite co-stars, or shall I say co-moderator, Jennifer Lowe, to introduce the speaker and the celebrity panel. So thank you so much. Jen, all yours.
Thank you so much, Ashwin. It's once again, another honor to be able to co-host with you and to share the webinar stage with our wonderful panelists and rising stars. So thank you to you and to everyone, making this event happen. First, I'd like to thank our sponsors for the entire season 2. And that includes Allergan, Elcon, Visus, Avellino, Dompe, Sun Ophthalmics, and Tarsus. Without their support, we would not be able to host this interactive webinar. And I'd especially like to thank Elcon for tonight's actual episode, being our special sponsor for tonight. And they have a short video, which we'll cut to showcase first.
I think all of us really love to share this with our patients. In the FDA pivotal trial, 99.2% of patients said they would have the same lens implanted again. This statistic was somewhat staggering to me when I heard it, but I can tell you this has been my personal experience as well.
That I'm truly able to deliver upon what I've been hoping to promise patients for a long, long time with prior technologies, in terms of truly distance, middle, near-range vision of high quality without compromise. The PanOptix has certainly simplified that whole discussion for me, where I don't really need to talk about trifocal, bifocal, diffractive, refractive. All the technology discussion kind of goes out the window, and we can truly focus on how do you want to see after we're all done.
Usually at the 1 week where I'll have the patient read on a near card, and they normally can read very small J1 plus. Then I show it to the family member who's sitting, back when we could have family in the rooms. I'll show it to the family member sitting over in the other chair who's got their thick glasses on. I'll say, your husband just read this with no glasses. And they look and they go, wow, that's unbelievable.
We're constantly evaluating our purchasing decisions on other people's insights. And to have that, for me to be able to say to my patient, well, you know what, there's a study that was done and 99.2% of patients said that they were satisfied, or, that speaks volumes. And I think that, ultimately patients want to know, do people like it? And is it safe? Do I, and all those things that, are the basic like check boxes. And the nice thing that I found in offering this even to this toughest population, the PhDs, the research folks, the engineers, is that when that population in my practice has been satisfied, it gives me even more confidence to recommend that lens to a broader category of patients.
Thank you very much. So now I'd like to share my screen here, and in order to present our amazing, wonderful panelists and rising star. So again, as everyone knows, this is episode 7 of season 2, and we're honored to have Dr. Rahul Tonk speaking to us tonight in advances in cornea and cataracts. As our first panelist tonight, who's graciously giving his time, we have Dr. John Doane, and he originally did college at the University of Missouri, Columbia, medical school at the University of Kansas in Kansas City, residency as well at the University of Kansas, and he did a fellowship in cornea, refractive, and anterior segment surgery at the University of Texas, and also he did a fellowship with the Centro Ophthalmology Colombiana in Bogota, and his current position is he's a cataract and refractive surgeon at Discover Vision Centers. So thank you, John, for your time. And also a fun fact, which we're doing tonight on everyone, is he likes to tear it up on the slopes. And I think he's getting ready for some skiing soon at the ACOS meeting. So we'll be seeing you soon, John. All right, next we have the wonderful, beautiful Dr. Ranya Habash. She did college at Wake Forest University, medical school at West Virginia, ophthalmology residency at Texas Tech, and she also did a master's of clinical informatics management at Stanford. She has many positions right now, including CEO of Lifelong Vision, Microsoft AI for Health, FDA Digital Health Network of Experts, and she's the medical director of technology innovations at Bascom Palmer. Fun fact about Ranya is she was born and raised in rural West Virginia, and she is fascinated with brain-machine interfaces. All right, and last but not least, we have Dr. Richard Lindstrom. He did college at the University of Minnesota, and as he just shared with us, I think he's the 4th generation Minnesotan. He's medical school also at University of Minnesota, a residency at University of Minnesota, and he did fellowships in cornea, anterior segment, and glaucoma. So a triple fellowship, pretty amazing. His current position is a founder of the Minnesota Eye Consultants, and he's an adjunct professor emeritus at the University of Minnesota Department of Ophthalmology. And a fun fact is that he also owns 3 Harley Davidsons, one of which was given to him by his wife as a wedding gift. And he also owns a construction company. So here you have it, our wonderful lineup of panelists who will be helping us with tonight's episode. Well, now I get to introduce the rising star, Dr. Rahul Tonk, who I also get to call a friend and local colleague. Dr. Tonk is from, he did college, at Cornell University. He also did a Master of Business Administration at Rutgers, medical school at Rutgers as well, and a residency at Albany Medical College in New York. He did a fellowship in the cornea external disease and refractive surgery at Bascom Palmer, and he's currently in practice at Bascom Palmer as the assistant professor of clinical ophthalmology and the co-director of cornea and refractive surgery fellowship and an associate medical director. So now the fun part of Rahul's introduction is we get to see lots of cool photos of him and his colleagues, and we get to let him take the stage and describe a little bit about these photos and what you're doing in them.
Yeah, well, thanks so much for the introduction, Jen. And again, to everybody involved, the celebrity panelists, the organizers, the sponsors, this is a lot of fun to be able to do this with you tonight. Yeah, this is just a great, first photo showing some of the people I work with. And, we have on the top left both my colleagues, my co-faculty who are once my mentors and now whom I get to call partners. That is a lot of fun. And then our recently graduated fellows there on the bottom, and the whole bunch of us celebrating at that same party on the bottom left. So we have old friends and some new friends on that bottom right. That is some of my co-fellows. Actually, if you look really closely, you'll see just to my right is Netta Nikpour and Dagny Zhu, who are my co-fellows at Bascom Palmer and who are prior guests of this Rising Star series last season. So Nandini Venkateswaran is also there. She was one of my residents on my first year or two on faculty. And then a bunch of other great faces, some new friends. So that's been a lot of fun.
Nice. Okay, great. Thank you. And here's a couple more pictures of you in the OR. Some pretty cool technology. If you want to say a few words about that too, feel free.
I like to do surgery. I think that speaks for itself. Yeah, everybody here does.
Very true. Okay, and last but not least, I love the family photo. So give us a few words about your beautiful family.
Yeah, well, so my whole family, we're all from the Northeast. We grew up in New York, New Jersey, as you can see from my training. Moved here into Miami in 2016. My wife was 8 months pregnant as I began my fellowship. And that's when we had my daughter, Sahana. So she counts the number of years we've been in Miami. So she's 5.5 now. And then underneath, or I should say shorter than her, I don't mean underneath her, but that little guy is Devan. He's my son. He's about to turn 3, and he is a true bread and butter Miami, and he's who's given us the courage to sow some roots in this community long term.
Really helps you make the program even more special. So now let me make sure I finish. Oh, sorry, one last slide. I like these activities, playing drums.
Yeah, I guess you'd asked me to share something about my hobbies and show people that I'm a real person outside of work. So here they are. Yeah, I'm very much into music. I spend a lot of time playing drums. It's a stress relief. I sold out my acoustic kit that you see there for an electronic drum kit, so the house wouldn't go crazy. I like cycling, and boating is new to me. I'm in Miami, so I'm learning the ropes around Biscayne Bay, and you can tell I'm a real diehard boater because I'm wearing a T-shirt that says Captain Tonk on it. So that's how you know that I'm good, right? But that's just sense. A little bit of humor.
Nice, I love it. All right, well, thank you. Well, now I will let you take over the mic and share us your presentation. Thank you.
Okay, great. Thank you so much, Jen. Thanks again, everybody, for taking the time to talk about a topic that I think is going to be really fascinating, and that's emerging trends in ophthalmology. So I do have some disclosures, none of which will be relevant to this talk. There is just one that I'll cover later as it comes up. So, in my heart, as I mentioned, I'm a clinician and a surgeon first, and that is how I dedicate 80% of my time and my energy. And I'm really, as we all are, fascinated by taking care of patients in the clinic, in the trenches. But so much of clinical care and complex cases and what would you do next, and so much of that has been covered by my other, co-rising stars that have covered cornea and refractive and cataract in prior episodes. So I wanted to figure out, okay, what can I do that's a little bit different, makes best use of the talents of this panel? So I brought together some of the other interests that I have, and of course, clinical research in anterior segment, education for residents and fellows, my background in behavioral economics and public health to think about healthcare systems, how we can deliver healthcare in a more efficient and certainly more equitable way on a domestic, on a global scale. So these are 5 areas of interest that I have, certainly, care being the principal one. And where they converge here is where all of our celebrity panelists have made their mark. This is the future that we want. And our panelists here have helped establish that future for us in the field of ophthalmology. We have some creative thinkers and some innovators amongst us. So this is what I think our audience wants to hear about. So what then would we say are 4 emerging trends in ophthalmology that are worthy of discussion? And granted, there's a lot in ophthalmology. We're lucky as a field, but 4 that I decided to highlight were same-day bilateral cataract surgery, dropless or less drops cataract surgery, virtual medicine, and artificial intelligence. So we'll go ahead and get started. So first, we'll talk a little bit about same-day bilateral cataract surgery. So everyone has had a patient like Mrs. Smith here that comes in after having waited a few weeks for an appointment, and after having gone through a litany of testing for her cataract evaluation, she's fatigued. And by the time I say, okay, we're going to do the cataract surgery, she's asking at the same time, right? I mean, how often do we have this conversation? So the discussion is real, but it is still an area of some controversy. In fact, in the January issue of the Blue Journal last January, there was a series or a pair of editorials, one from Ike Ahmed, Warren Hill, and Steve Arshinoff, really saying that the idea the idea of same-day bilateral cataract surgery is ready for prime time. And then Sam Maskett writing, on the other hand, that there may be some limitations here we should be considering. So what are the benefits? Well, the main benefit is convenience to our patients, in the sense that they have to take less time off, less time spent in the clinic, potentially less travel, and certainly being cognizant that these patients have a lot of working age children or spouses that have to bring them back and forth to appointments. We also talk about improved efficiency or access to care. So as the physicians are less bogged down with postoperative appointments, let's say, that might allow them to and create additional slots to allow additional patients to come in. So in resource deficient or ophthalmology deficient areas, that might allow the healthcare to be delivered more efficiently. Certainly a more rapid visual outcome is always nice, and then stabilization of anisometropia if you have a big gap between the eyes and you have a big difference. Certainly the big winner is the third-party payer. And a 2014 study showed that Medicare alone stands to gain about $500 million in cost savings if surgeries were allowed to be done. Well, I shouldn't say allowed, if surgeries were done by default as same-day bilateral. So what are the limitations? The number one that I think people think about is safety. So what if something terrible happens to both eyes at once, like endophthalmitis? Well, to date, there are only about 4 cases that have been reported in the literature. Granted, that might have been a little bit underreported. But there's an international consortium now of surgeons that are trying to make bilateral surgery safe as possible. Update on surgical techniques, changing drapes and gowns and gloves after each eye, using disposable instruments and changing those disposable instruments out, and making sure that they're from different lots, using prophylactic intracameral antibiotics. I mean, there's a lot being done to make sure that this happens safely. The other limitation might be refractive issues. So some people like to have a post-op day 1 or a week 1 visit where you judge how you're doing on the first eye before you do the second. In an era where we're getting more accurate with intraocular lens power calculation, or in an era that we can adjust post-operatively power with light adjustable lenses, this might be less of a concern, although we haven't quite cracked the nut of dysphotopsia. So dysphotopsia is in monofocal and certainly in presbyopic correcting lenses. So let's hope that that improves over time. Reimbursement is the big limitation. So here in the United States, Medicare reimburses, and most commercial payers also will reimburse only 50% on the second eye. So those that are doing cataract surgery on the same day are typically packaging it as part of a premium offering together with premium IOLs to make up for that loss in third-party pay. And then certainly there's a question of medical liability, although to my understanding, I don't know if any cases have been brought. So between the benefits, the limitations, I want to open up to our broad panel here and a couple questions to get us jumping off. Do you offer, or does your practice offer same-day bilateral surgery? Why or why not? What are the barriers that you see? And do you envision a future where same-day bilateral surgery might be the norm or the default?
Rahul, I'll jump in on this one if I can. Do I offer same-day bilateral cataract surgery? I don't, but I offer same-day bilateral laser vision correction. I offer same-day bilateral refractive lens replacement. The hurdle for me, and has been forever, really, it's the reimbursement in the US. It's impossible for me to kind of grasp, certainly in a non-premium case, that we take home half of the facility fee and half of the surgeon fee on the second eye. I would give the analogy, you want to sell a car, but the person says, hey, I want to buy two, and you're going to sell me the second car for half price. You know, it just, from a financial standpoint, it just is such a disincentive to do this. Whereas I feel completely comfortable doing bilateral same-day refractive lens replacement, same-day bilateral ICLs. I would love to offer same-day bilateral cataract surgery. And I think the one thing you kind of touched on, it's one thing for the patient, but invariably for the, over age 65, they have a child that's working that has to take time off, one for the day of surgery, for the first surgery, for the second surgery, and for two post-operative visit day ones. So for all these reasons, I'd love to do same-day bilateral. If it could work out that we were getting paid appropriately, I would do it, and probably every patient would want to do it in the US.
Yeah, I think that's a big limitation, as you mentioned. Does the rest of the panel, Dick, Ranya, do you have any thoughts there as well, going off what John said?
Well, we do some same-day bilateral cataract surgery, mostly in younger patients who are retarded and will require a general anesthesia. The special situations is really where we usually do it. Do it today, and the barrier is definitely a reimbursement barrier. I don't believe that it's a risk barrier, and I think actually with most patients, given the choice, would rather have a bilateral same-day sequential surgery. It's definitely, in my opinion, the future, and there's still many surgeons, especially in the Kaiser system and other prepaid systems, that are using it as their primary approach today. But if I look ahead to the younger surgeon, maybe someone being trained 10 or 15 years from now, I think they'll be surprised that we used to do them one eye at a time. I mean, they'll kind of go, what? You did one eye at a time? That doesn't make any sense. They'll be doing almost certainly 90% plus in the non-complex cases, bilateral same-day sequential surgery. It'll be driven by the patients. Reimbursement will change. And we have a shortage of manpower and woman power, if you will, as far as surgeons go. So those three things will drive it.
Right.
Yeah.
And sorry, Ranya, please.
No, it's okay. Go ahead.
Well, I was going to ask a follow-up on the reimbursement front. Yeah, I mean, that is certainly, in my practice, that's the major limitation. And just as the both of you had mentioned, I do same-day bilateral if I need general anesthesia on a special needs patient. Those are the situations in which I practice. But there are surgeons in my area in South Florida that combine it as a premium experience for patients willing to purchase premium IOL technology. I do have my concerns about whether that sends a message to our payers or our third-party payers if we're willingly devaluing our services until that change is made. I'm just curious to hear your thoughts on that.
That's
Ranya,
exactly what
and
I was
others.
going to say. Yeah, that's exactly what I was going to say. I mean, I think it's absurd that we let the insurance companies dictate what we know is the right thing to do, right, for a patient. And we shouldn't devalue our services. I mean, if you go see an attorney, if you need 2 hours of their time, they charge 2 hours of their time. They never say buy 1 hour, get the other half. And so I don't understand why these rules are, given to us, and we are not allowed to change them. So I would just say that, we all need to kind of pull together and make this an argument, for the payers, because we all know it's the right thing to do in the majority of cases. I do agree that, if I'm looking at a refractive result and I want to separate the two, that's an exception. But for the most part, yeah, I mean, there's no reason with some of the disposable instruments that we have these days and some of the other safety measures that we're taking, that it shouldn't be done at the same time. So I agree with the other panelists.
Yeah, great. Well, I think we have a consensus there. So I'm going to move forward into our next topic, which is going to be a discussion on dropless or less drops cataract surgery. So the ASCRS survey on, well, let's break this down into a couple different areas. I mean, the drops conventionally that we're using are an antibiotic, a steroid, and a non-steroidal agent. At least in the US, that's the standard three. So the first discussion is on antibiotic. And the question is, what is the penetration of intracameral antibiotic use, at least in the US? So the ASCRS member survey done by David Chang and Doug Ree just came out. And you can see the trends over time here. If we look on this row, intracameral antibiotics, here in 2007, about 30% of ASCRS members were using intracameral antibiotics. 2014, that number went to 50. And here in the most recent survey, you now see a majority, 66, but 2/3 of ASCRS surgeons are using intracameral antibiotics. Now, granted, there's some selection bias, the people that would respond to the survey and ASCRS members, but I think that's still pretty remarkable. And that follows what I think many of our European colleagues are doing. When we ask the patients or the surgeons that are not using intracameral antibiotics why, that survey then went on to say mixing or compounding risk was the most common issue, with almost 66% of those respondents saying, I'm afraid of a mixing error, or this might be off-label coming from a compounding pharmacy. I don't have anything on label here. Cost was an issue. And then a decreasing number of surgeons said they weren't convinced of the need. Back in 2007, 90% people said, I don't see the need. I don't see endophthalmitis in my practice. Why would I do this? And certainly that number has gone down. That is to say, there's not zero side effects or complications of intracameral antibiotic use. And these things are, granted, they're a little bit rare, but we have from intracameral vancomycin cases of hemorrhagic occlusive retinal vasculitis, many of which were described here by colleagues at Bascom Palmer in Florida. And then, okay, well, we're moving away from vancomycin. How about intracameral moxifloxacin? Okay, safer, but how about acute iris transillumination defects? These are in the case report level, but they occur. Certainly toxic anterior segment syndrome or endothelial injury is also a concern. So in this survey, about 5% of the respondents who were using intracameral antibiotics said that they had encountered at least one patient with a complication like TAS or endothelial injury. That's not that 5% of intracameral, receiving patients have that issue, but 5% of surgeons using it have had a case. Are those numbers less than the risk of endophthalmitis? Are we doing the right thing? Well, we'll see. I mean, ASCRS looks to be engaging with the Veterans Health Administration on designing a trial. So hopefully we can get some more info. So other intracameral agents. So we'll talk here about let's say, extended release steroid. On the top left, these are both FDA approved on-label drugs here. The top left is the Dexacu. This is an intracameral sustained release intracameral steroid, which is injected into the ciliary sulcus. You can see it hiding around there. And the other is Dextenza, which is a canalicular insert that's put into the punctum at the end of cataract surgery. These two medications have a lot of data on them, and certainly they're popular in some of the magazines. There are also old-fashioned ways to give steroid, and that includes the off-label use of subtenon's triamcinolone, which a lot of people do dropless on the cheap using a subconj triamcinolone injection with an intracameral moxie, and they get away with it, adding NSAID as they need. The next broad area is non-steroidal agents, and taking from, we have on label Omidria, a phenylephrine ketorolac injection that's put in the irrigating bottle and that irrigates through the eye, and that has now data that's shown that reduces certainly postoperative pain, inflammation, and then also potentially reduces the risk of CME in patients. So ketorolac, a proven drug. Problem is getting an NSAID into the eye has always been difficult. Patients complain of stinging, there are melts associated with that, and so forth. Here's a new technology that's coming, and I'll disclose I have a financial interest in this, and that is the OcuRing, developed by a company called Layer Bio. And here is their kind of premier leading candidate. This is a ketorolac biodegradable sustained release insert that's applied onto the intraocular lens and is put in. And their phase 1 data, I should say, in the patients that had this implanted, no steroids were given, and in fact, no patients required steroids alongside this lens insert. Certainly, aside from complete dropless surgery, there are other options, and we're finally getting around to having some compounded agents like those that Imprimis and OSRX are preparing, that are combination of pred and moxie and bromside and bromfenac and that sort of thing. So that's also fascinating to watch too. So coming into our discussion here, do you favor a dropless, a less drops, or a conventional postoperative care regimen for cataract surgery? And if you believe in a dropless suture, what's needed to get us there?
Well, I think this feeds into the first discussion a little bit, which is bilateral same-day sequential surgery. And pretty much everyone that does that utilizes an intracameral antibiotic, to reduce that dreaded risk of a bilateral infection. So I think we've already gone, in that direction away from topical antibiotics. As more than 50% of U.S. surgeons are using intracameral. I think we're going to go away from probably all drops over time. It'll be the same story as I said before. Patients will be surprised, and younger doctors that are in training be surprised that we use drops. 10 or 15 years from now, that won't be the case, and it's going to be convenience, cost, and another big issue is compliance. If you really ask your patients to put their drops in their eye in front of you, you get some really interesting surprises. In my career, the most impressive I had was when I asked the patient to show me how they use their drops, and they stuck their tongue out and put the drop on their tongue. So
we all have those patients that open their mouth.
I think we should take charge personally as surgeons of the postoperative medical regimen, and that'll take us away from drops.
Yeah. So if we talk about, the staggered cases, like 2 weeks apart or 1 week apart, just imagine, using 3 drops 4 times a day in each eye, staggered like that. I mean, it's a mess for the patients. And I do think, I totally agree that this contributes to non-compliance quite a bit. I echo everything that Dr. Lindstrom said. And actually, remember the sandbags, right? Remember, we don't use sandbags anymore. We used to think everyone was using them before, and now we can't even imagine that. So I totally agree with you.
So John, what do you think it's going to take to get a sea change? I mean, do you think we need a new therapeutic that works, that has an appropriate cost? I mean, what do you think the main holdup is to moving this direction, or what would you like to see our industry partners or our research partners work on?
Yeah, I think we probably hit it pretty well. I think in the ASCRS data, you're getting a subset of surgeons that are, if you want to call it, progressive and want to make things simpler for their patients. I don't know how much of this comes down to surgery centers and cost and so forth that may have an impact. I am like, Dick and Ranya, it just makes so much sense to make it simpler for patients. And again, the the one thing I would say is, the cost of drops are not inexpensive. Sometimes when you see the bills that patients come in with the topical drops, they just about tear your want to tear into you because it costs more than their copay for doing the cataract surgery. So anything that we can make things simpler and less expensive, and if the pharmaceutical partners can help us with that, I'm all for it.
The
And how about
future is Dr. No. It's going to be no IV, no patch, no drops. Lots of no's to things that we think are routine today, and they aren't going to be routine in the future. So
that's good. I like that.
That's interesting, Dick. For years I tried to make it where no IV, maybe give oral sedation at most, but there were just certain select patients that they just want to be snowed. I mean, they want an IV. They're fine with doing bilateral same day, but they're younger, they're anxious, and I just simply can't get away from having a CRNA and helping me out to get them relaxed. So that would be awesome if it. I know some people do the sublingual melts. Maybe that would help and avoid the IVs.
Do you think with where we are right now, without an on-label injectable, do you have concerns? Do you share the concerns that some of the ASCRS survey respondents mentioned about compounded or some people are using Vigamox, preservative-free Vigamox right out of the bottle? Do those concern you as users of intracameral antibiotics, or do you feel like that's pretty well established or taken care of now?
I think that I can see why people get scared. I mean, I've seen him talk to people. There was a huge episode of toxicity in Dallas where, there were numerous patients, actually dozens of patients, several with extensive vision loss from improper compounding. So I can totally see where some people come from that perspective, that they just want to see something that's a little bit more definitive and foolproof.
Right.
Yeah, we all want FDA approved drugs, and I mean, we have replacements for steroids. We have potential opportunities for antibiotics. We don't have an intracameral NSAID that's ideal yet that has long-term efficacy, although it may be that Omidria, has a longer impact than just 24 hours. But in the future, we're going to have these options, and they're going to be FDA approved. So our pharmaceutical manufacturers, well, they're working on it, and I think we'll have it.
Great discussion. Okay, so now we'll get into some of the more technological aspects, should I say, of the talk. And the next talk, I can see Ranya smiling because this is her baby here. This is virtual medicine that we're going to get into. So we'll talk a little bit about virtual medicine. I think that this is, certainly something that people surgeons got very, very comfortable doing, patients got comfortable doing during the pandemic. A lot of the reimbursement issues were sorted out with the CARES Act. And certainly the technical issues were sorted out as, a lot of energy was put behind delivering care despite this, very unique global event. So we all know, ophthalmology has been actually on the forefront of telemedicine for a long time before COVID as a field. During COVID, certainly telemedicine visits took off, and under the leadership of Ranya and our chairman, Eddie Alfonso, some others, Bascom Palmer was able to respond to that very quickly and increase the telemedicine utilization. The question that I have, though, is when we look at the data on the whole, and this was a paper that came out in Ophthalmology last year, and what is the longevity of telemedicine, and how much sticking power can we get there? Because if we're following this chart, this is all ophthalmology visits from 2019 to 2020. Okay, the black line dips down here as we go into lockdown, and here goes telehealth in the blue, way up there. Okay, now we're opening back up. So in-office visits come back up, and there goes down telemedicine as expected. We are higher than we were to start, certainly on this side, but geez, did we make up for the missing visits up here? Why can't telemedicine stay up over here? Why can't we have a 10 or a 90 or a 20 or 80 or something like that? I think that part of the reason why is that ophthalmology is a very exam-heavy specialty. We're used to looking things at the slit lamp, dilating patients, looking at the retina, checking their vision and eye movements. And so at least as compared to other subspecialties, we might have been eager to get back patients back in the clinic. In my view, that sort of bias is because telemedicine is stuck in this kind of sense of being a synchronous AV conversation, inefficient AV conversation, where you could accomplish much more in a shorter period of time for an in-office visit. And I think that, we now have to contend with, do we have a telemedicine 2.0 movement in the post-pandemic era where we can utilize everything that we've learned and everything that we've accomplished in terms of reimbursement structures? So there's a lot of different things that telemedicine 2.0 can accomplish for us. And on this exhaustive list, it's not completely exhaustive, but on this list, each of these is reimbursed, and Medicare has set the stage for that. But I want to tie into 4 specific areas, and those are hybrid visits, second opinion consults, virtual urgent care, and remote patient monitoring. So hybrid visits, I think this, for me, in a post-lockdown era, is probably my most utilized form of telemedicine now. And the basic idea, I think, for all of you that are doing hybrid visits is pretty simple. Patients, let's say a follow-up patient comes in for glaucoma, and I say to Ms. Smith, okay, come back in a couple of weeks. I want to check your pressure and do a field. Well, I don't necessarily need to have a long conversation with her in the clinic or have her sit in a chair waiting for me with all of her imaging done. So she can have her visit scheduled. She can come in. My tech can check her vision pressure basics. We can send her for her field. She can go home. And then at a separate time later that day, when I'm done with clinic or in-office visits, what have you, I can review those results and give her a call. And there's a reimbursement pathway for that. This, to me, is a much more facile and efficient way to deliver care, and patients are really happy to receive care in this way. Second opinion consults, another area that I love. We receive, as a tertiary referral center, a lot of international referrals for patients that have complicated disease or need multi-specialty coordinated care. And sometimes it breaks your heart. You have people, particularly in the pediatrics realm, you have parents who have sold assets or taken second mortgages to be able to afford a visit to come to the US and be seen. It's hard. It's hard. And you feel pressure as a provider to do something for a patient in that setting. Well, we have, and again, with the leadership of Ranya and several others, we have converted a lot of this to a virtual format. So we have these second opinion consults done now where the patient sends in the data that they have, the medical records they have. If there's additional imaging needed, certainly that can be done local on ground in almost all cases. A flat fee is collected up front. The staff makes an appointment, and then you can have multiple doctors talking virtually at the same time. Here you have Dr. Habash, Dr. Maskell, one of my ocular surface specialty colleagues, and Dr. Will Harbour is an ocular oncologist talking to the patient here. So it's a very nice opportunity for patients. And I believe it speaks to the equity about making medicine available to all corners of the world. One of the big other accomplishments or big areas of interest of mine is this kind of sense of rapid virtual eye care. So this is a program that was launched to reduce the congestion, let's say, in the Bascom Palmer emergency department. So can we find a way to triage subconjunctival hemorrhages, itchy, dry eyes, and these sorts of things out of the ER so patients in the ER get the care that they need? And this was done really successfully with about 91% of people calling in virtually and describing their complaints, not ultimately needing to come into the ER. Only 9% really needed to be seen emergently. The rest were either given recommendations and followed up with their local eye doc, or were referred in an expedited manner to the relevant subspecialty. And then remote patient monitoring is the last big piece that I want to touch on telemedicine. This is a very fascinating area to me. What has been around for a long time is things like these web-based visual field testing, web-based macular testing, where basically Ms. Smith logs onto a computer and she's able to do, a visual field test. The webcam is checking her fixation here, and then there are stimuli off to the side, and she clicks when she sees them. Those results are then sent to the monitoring MD, and the MD is alerted if there's a problem. Now, the MD in all of this is actually reimbursed, and there are Medicare codes for remote patient monitoring now, which is exceptional. Big revolution in a way there. But these web-based exams are kind of old news at this point. They only really screen for moderate to advanced glaucoma. They're not really sensitive for detecting progression or detecting early glaucoma. So you have other now at-home devices. This is the 4C Home. It is basically a device where you have these Amsler grid lines. The computer will put a little bump in the line there. A patient's fixating on this target, and as soon as they see that bump, it disappears. The patient is then going to click where that bump was. And this is a modified version of an Amsler grid. And then you have some other opportunities. The eye care tonometer, this is a non-invasive, non-anesthetic tonometer that can be applied to patients to check at home. And then the nodal vision, which is going as far as doing at-home OCT. Okay, so these devices start to get a little bit pricier, but I think that as our industry partners see the market value here, and as third-party payers are willing to accept their value, I think that the pricing of some of this will come down and put it within reach. Another area that has been interesting is making perimetry in particular accessible without a big Humphrey visual field machine or what have you. And two technologies that have come out of this that are interesting to me at least are the All Eyes Visual and the Hero Revive. And these are basically headsets that test visual field perimetry, visual acuity, color, contrast, many more different things, all in a portable headset. And right now it's in a headset, but you can imagine, and it's tested in office. That's where it's marketed right now for office use. But you can imagine a time when this gets into a smartphone on a virtual reality headset, and it becomes affordable to the patient. So those are the key areas that I wanted to touch on. Of course, there's a lot else we can get into. Doctor-to-doctor consults. You know, if you have a difficult, if I've got a question and I need, John, if I need your advice on it, and the patient, I consent the patient, I said, I want to reach out to my colleague, Dr. Doane. Well, with that patient's consent, I can then consult with you. I can get reimbursed for having initiated that consult. You can get reimbursed for giving me advice. We've been doing curbsides like this for decades, and now there's a pathway to get reimbursed for it. IOL counseling virtually, staffing trainees and residents and helping them understand what they're looking at or what they're seeing, getting reimbursed for quick emails and responding to those emails. And then, more interesting than any of that stuff, I think, is autonomous screening, which is using some of these devices either at home or in the clinic to autonomously detect for disease and then to make the appropriate referrals into a telemedicine encounter. So that was a lot to touch on, but a few different areas that I want to get into as a panel here. How does telehealth fit into your practice? Was it something that was mostly used during the pandemic? Have you continued to use it, and in what fashion? What pitfalls do you see for telehealth? What problems do you see with it? And then what innovative applications for telehealth would you most like to see?
Rahul, I'll jump in real quick. You know, one thing I was going to say that I really like is your virtual rapid screen that goes to your ER. You know, the one thing you didn't have on that pie diagram was styes. So one thing that's kind of interesting me, that I will see streams of these people coming on occasion. You know, friend is on a plane, takes a picture of his eye, sends it to my smartphone, and what's this? Well, it's a sty. And so I love the idea of people being able to take a picture of their eye, if it's a sty, if it's a subconjunctival hemorrhage, something that we could do over the phone and not have them come in for something that really is very straightforward. So I love that aspect of what you're doing at Bascom. I think that any practice could utilize that and do well with it. You know, the one thing that I have done, I'm primarily refractive based. The two things that we've come back from with the pandemic is created is our 1 day post-op laser vision corrections. They were used to, we would see all of them one day. Now, essentially 100% of those are virtual. The only time we see somebody post-op day one is if there's something of issue. So that has been going now for the last 2 years, and we see the patient for the first time post-operative at 2 weeks live. Otherwise, it's virtual. So we've kept that going. The one thing that we have done, and this is more from an educational standpoint, is virtual screens. So we've done, in-house screens forever, but we've implemented virtual screens, and it kind of just opens up the funnel for people that are kind of interested and may not want to come in. And we just, essentially have a camera in front of their computer. They show us their contact lens prescription, their glasses prescription, and we just walk through that process. That is something I think that will continue with our practice going forward. Again, refractive based.
Yeah, I can jump in here. There's so much to talk about, when it comes to telehealth, but let me try to start. So first of all, the cataract counseling or refractive counseling is a huge hit with patients. They're sitting at home, they've got their family members there, they're not wearing a mask, you're not wearing a mask. Most of the time I'm sitting at home and doing the counseling. And as a byproduct of that, we saw without any shadow of a doubt, our refractive rates increase. Patient conversions. That's not why we did it, obviously, but that's what happened. And it's because all the family members were sitting there and, able to weigh in on the decisions, and the patients felt more comfortable just because they weren't being rushed and felt like, they were alone in the doctor's office with a mask on and with the doctor with the mask on. So that visit is a no-brainer. It's also a time-based visit. So you spend 1 hour counseling, you get paid for 1 hour counseling. It's not the same as a regular visit. So you should always keep that in mind too. I mean, there are benefits to that for the patient and for you. Aside from that, going back to the rapid access clinic, which has been super successful. I mean, every single slot is full all the time now. And it's Chalazion was on the list. I think it's listed under anterior segment or something like that. But that was the majority of patients that we saw. And you're absolutely right. I mean, how easy is it to just send a picture in? Rahul, this wasn't just a phone call. This was, these are all virtual visits. These are all telehealth, video visits for the most part.
I hope I didn't say phone call. No, of course it was an AV visit.
Yeah, because you said they call in and, they get a request. I mean, it's not informal like that. We do a formal.
No, of course not. Of course not. Sorry, I've given that impression.
Yeah. I'll just make a really quick comment. And in our Minnesota IR practice, we haven't found this to be a cost-effective use of the consultative ophthalmologist time, but we obviously do a lot of, in quotes, telehealth, but we delegate most of it to our optometric colleagues, our physician's assistants, our technicians, our nurses, our surgery counselors, et cetera. So there's a lot of telehealth going on, but I think I would say the least amount of it is being done by our ophthalmologists. So I think maybe that's probably the way it is in most clinics.
I mean, it shouldn't be that way. This is a potentially practice changing talk that you're giving, Dr. Tonk. So I think it's good for people to hear what the best practices are like in other places. Going to like remote patient monitoring, for instance. It's right now we have patients hang up an Amsler grid on their fridge, right? And we tell them to look at it every single day. But if you do a SAS-based dynamic macular grid testing, which is what Keep Your Sight does, for instance, then, that's something that you can assign to a patient every single day. And guess what? You're getting a fee for that. And the fee is like it's about $130 per month or so per patient, recurrent, annuity, basically. And the patient feels like they're in much better control of their health. So it's such an easy visit to do. And I think it's a game changer for the entire industry.
We're agreeing a little bit. I think the ophthalmologist will probably analyze the data, but the ophthalmologist may not call the patient to discuss the findings with them.
You have to, though. I mean, that's part of the payment strategy, but you are only obligated to do like 20 minutes per month cumulative time. And that can be all of your office staff, as long as you have one real-time conversation with the patient. Even if it's, hey, continue present management, you seem to be doing well.
Right. But yeah, again, both points valid. And, I think to Dick's point, what John was saying earlier about the styes, I think a lot of our rapid virtual eye clinic is staffed by our optometrists. There's so much more that we can get into. I think that, certainly I'm doing less telemedicine than I was during the lockdown, but I'm doing different telemedicine, and I'm doing it in a sort of a supplementary way instead of a replacement way. So it has been interesting, and we'll see how things move on. So our last topic that we'll get into here is a very, very fascinating one, and that is artificial intelligence. So just to kind of give a primer on AI, somehow I have to describe AI in 30 seconds here, but the concept of AI, it's been around for a long time, probably 50s, 60s, where computers or machines were designed or programmed to mimic human cognitive functions. But more or less the programs were, or the machines were programmed, and then they would do what they were programmed to do. Revolution number one came around in the 90s, which was machine learning. And the basic idea was to expose the computers or expose the algorithms to the real world, expose them to examples, and then let them learn, let them modify their algorithms on a continuous basis to improve those algorithms over time. And that has been around for a while, actually. What is new and what is causing this explosion fascination in artificial intelligence is deep learning. And deep learning has really taken off in the last, I would say, probably 2015 is the time that people will point to and say, okay, that's when deep learning really came to be. So that's relatively recent, and the field is quite young. And the applications for deep learning, there's a handful. One of the big applications is computer vision, which is to give a computer or a machine the ability to take in a picture that we give it and to make sense of it and say, okay, that is a dog, that's a cat, that's a picture of a man with a hat. I feel like I'm Dr. Seuss over here, but you get the idea. And other applications, speech recognition, language translation, robotics, these are coming. And these are the applications that we're looking for deep learning to be working on. So to kind of give a general sense of how a deep learning algorithm will work, you have to first train the algorithm. You have to have labeled images that belong to the object. So let's say in this case, we've got two images of a cat. We know that these are a cat. Then you got an image of a dog. We know that that's not a dog. So we feed them into the algorithm, and the algorithm has several layers that it goes through. This is called a convolutional neural network. First layer is going to do something basic. It's going to break down the image pixel by pixel, and it's going to say, have you got an edge? Is this the edge or an outline? Each node within this layer is then going to say, okay, I have a certain level of confidence that, yes, this is an edge. And then it's going to move forward to the next layer, which is going to say, okay, well, is this a shape? Is this a curve? Is this a triangle? Is it a circle? And that is going to feed back into the first layer and help make predictions as the layers move on until you get to the final layer, which is a prediction. Is this a cat? Yes or no? And if the prediction is correct, good. If the prediction is not correct, well, we got to go back in and we got to adjust these weights on these nodes and figure out what the algorithm did wrong. Now, the AI is doing this on its own with enough test images that are labeled. And it takes about it takes thousands of images to train the AI to do this well. So that plays into why this is so critical, or why ophthalmology has been so involved in artificial intelligence. In fact, if you think of AI as being a big deal right now, we're on the ground floor of AI, and ophthalmology is on the ground floor of AI. In a way, I mean, if you can think of what are the best possible applications of AI in human society, they're not to develop better advertising. And I think that, despite what we may think, most of the, well-meaning engineers want to do something better with their time and with AI. And part of what they want to do is improve health and improve healthcare. So where in healthcare is all of the attention going with AI? Well, it's going into ophthalmology. Well, why ophthalmology? Well, one of the reasons is we've got a lot of data, tons of images. And we talked about image recognition is key to train these algorithms and develop computer vision. We also have a sort of non-intrusive way of investigating the eye and the human body through fundus photos, OCT scans, as compared to CAT scans, MRIs, and PET scans, and so forth. We have always known that the eye is the window to the body, and the computer is learning that as well. And it's taking fundus photographs and predicting cardiovascular risk factors and neurodegenerative diseases. It's pretty impressive. So I'll briefly touch on what the most famous application of AI in ophthalmology is. That's diabetic retinopathy detection. And DeepMind, which is a Google subsidiary, partnered with Moorfields right around 2016 to develop these algorithms to look for diabetic retinopathy. Within a handful of years in training, the algorithm was identifying and grading diabetic retinopathy in a superhuman capacity, so better than the retina specialists or the ophthalmologists were doing themselves, or with a greater sensitivity and specificity. The FDA then approved AI-based medical devices for screening for DMR in 2018, and just in 2021, CMS has announced payment for artificial intelligence-based diabetic retinopathy screening. So there are some instruments that accomplish this. But the field is continuing to grow. I mean, we have now, in the last 5 years since deep learning has come out, you have 100 papers. Every month there's a new paper coming out talking about AI in ophthalmology. I mean, the key one was diabetic retinopathy. That's what got us started. And glaucoma is going to be the next. And that's the one that's kind of moving us from looking at pictures of disc photos to also looking at OCTs, multimodal imaging as well, combining the concept of pressure, age, OCT scans over time, visual fields, this data that we know it's hard to make sense of as a human being when you're working through so many patients at a time. The AI is taking it all in. Certainly macular degeneration is on, cataract, several others. When I think about the cataract evaluation and what we need to do to come up with an appropriate surgical plan, the correct intraocular lens, the correct toric power, the correct axis in which to place it, making sure there's no macular disease, making sure that the surface is pristine before we do it, and then carrying on with surgery in a safe manner. I mean, you can just imagine this is ripe for integration or support with artificial intelligence. So there are a number of different applications that we touched on. I think screening is one big one. Screening is going to be useful not just to, here in the US. I think it's going to be screening worldwide, particularly in developing countries where access to ophthalmologists is not as easy, or patients have to travel at great expense to be seen by an ophthalmologist. You can imagine having an outpost AI device to screen and make appropriate referrals. Certainly for the practicing ophthalmologist in the office, I think we're going to have augmented decision-making. Never miss anything is the, let's say maybe it might be a bit of hype, but that is the holy grail, so to speak. And then moving along, we can imagine AI working with protein folding structures and 3D modeling to figure out, what drugs and what therapeutics we have to come out. So, I mean, we are at ground floor on AI. I mean, just in the last couple of years, this stuff is taking off, and ophthalmology is at the core. So very, very fascinating stuff. There are some limitations. You got to be careful. We still today do not have too many real world examples of AI being super successful in a deployed setting. I think that's coming. But that AI that I referred to, that superhuman quote unquote AI that I referred to earlier, was deployed by Google in Thailand, and famously across the tech world, it did not do as well as planned. And it kind of over referred patients, or the data that was acquired was rated to be of poor quality. It was accurate in the lab, but when you go into the real world, you need to be able to hit that as well. So that was a learning trial for AI developers. And certainly, we don't know what's in the black box of AI. We don't know what those layers are and what AI is going through to train itself. And one of the issues that has come up is a bias in the AI algorithm. Amazon tried to use AI to look through resumes, and what it found is that AI was picking up on our own racial and gender biases in terms of recruiting men more than women, or recruiting certain, disadvantaging certain races and so forth. So we have to devise AI in a way that's equitable, and maybe ask the AI to show its work and tell us how it's coming to these conclusions. So with that primer here, we can take some time for discussion. So AI is here. I think it has a long ways to go, but we're here at the ground floor. What applications of AI are most compelling to you? what do you think is real? What is hype? And what potential challenges might you see as AI picks up speed?
I'll go first on this one. You did such a good job explaining backpropagation algorithms. That was awesome.
In 30 seconds.
That was really, really good. I'm super impressed. Okay, so where do I start here? So I think, screening is certainly one of the most compelling things. And in real world scenarios, I mean, we did see evidence of AI doing really well. For instance, during COVID in the NHS, when it was basically elevating or escalating cases or lung x-rays that looked like they might have COVID, right? So those patients would get triaged faster and get treatment faster. That was super successful. And the machines learned a whole lot of information from those images. One of the things that we did at Bascom Palmer a couple of years ago with the work with Microsoft is we took about 86,000 images that we had, real world images, and trained the machine using Microsoft's supercomputers and did algorithms for macular degeneration, glaucoma, diabetic retinopathy, ocular melanoma, and a normal category, and then substratified them even further. So that convolutional network was really deep because it was not linear. It wasn't yes or no, you have DR. It was mild, moderate, severe, with and without, et cetera. So, I mean, these things are coming, they're going to be everywhere. And we are best served by, jumping on this first and being able to try to control it and steer it. And yes, there are going to be downsides, but I mean, hey, we use AI for everything right now. We use AI when we go shopping on Amazon. And if we just work at it, we're going to make it even more useful in augmenting ourselves. I think you used a really good choice of words there too. I'll stop there. Sorry, I don't want to take this whole
No, that
time.
was great. John, Dick, what do you think that AI, in what way do you think AI, as it comes to be, would be most helpful to the practice of ophthalmology?
Real quick, Rahul, just jumping away from ophthalmology real quick. I think of the one field of medicine that this seems like it could take over and almost negate needing a doctor would be radiology. I mean, radiology, like ophthalmology, it's so visual. It's I guess repetitive in nature, that it seems like that would just be such a powerful place. I think obviously, and you've already named the big diseases that are going to take away vision, macular retinal disease, optic nerve disease. That just seems like such a no-brainer to get started. And that practitioner, even if you're a greenhorn, if you have that data, you're going to make a much better decision, either continue current treatment or refer that to a specialist or get help in taking care of that patient to preserve vision. So to me, it just seems such a powerful thing going forward.
Yeah, and what you said, Rahul, about like predictive analytics for glaucoma. When we're synthesizing all this information about age, race, family history, et cetera, with PACI and IOP trends and all that, I mean, that is predictive analytics. That's exactly what the AI is supposed to do and help us with. We ultimately make the decision, but that is there to help serve us, and so we can serve our patients better.
Yeah, that's the real key, is that to help the clinician. I think glaucoma is pretty complex, and then even deciding what's the ideal therapy, especially when we get into doing more genetic profiling as well, to pick the genetic profiles that respond the best to one treatment versus another, et cetera. It's going to be hard for a clinician to do that without artificial intelligence. So I agree with that. That is going to play a major role in ophthalmology, and it's going to just be helpful to the clinician. It's going to point them in the right direction in a lot of cases. I think it's a little bit like we get a reading on an EKG, but we still read the EKG. I think we're going to get a lot of help from artificial intelligence. It's already helping us probably in IOL power calculation and also in certain screening settings with diabetic retinopathy.
Right, and that deserves to be mentioned with the Hill RBF and the latest PUS formula that are continuously optimizing. Yeah, I think that it's certainly here, and I'm excited to see it and watch it grow. So that concludes.
It won't replace the clinician; it will help the clinician.
Oh yeah, I absolutely think so. Yeah, I absolutely think so. And to John's earlier point about about radiology. That's certainly a point of discussion, active discussion in AI communities and amongst radiologists. And I think that the AI developers, tongue in cheek, they said, okay, the field of radiology is over. But I think that what we're finding is that, just like anything else, it's augmenting the radiologist's ability to harness the power of that AI and put it in a clinical context, something that is going to be relevant to the care of patients. So I think it's going to be fascinating. I think, do any of the panel share any concerns that AI might be a replacing or taking work away from practicing ophthalmologists? I just want to see if that's a concern.
I have a question.
I don't know.
We're never going to be able to see as many patients as we need to. And when we talk about true access to care, this is what's going to help us deliver that.
Yeah. John, you had a comment.
I have a thought. Yeah. So, when I was in medical school, like day one, and I still use this when I teach residents and students when they come through, is that I remember an old timer saying, history gives you 95% of the diagnosis. So if you listen to the patient, that will direct you to the diagnosis. So I think the one thing that we can get tied up with technology is you could do 100 tests, but you just have to ask the patient, what's going on. And usually within, I think any clinician, within about 30 seconds, what you're looking for. And so I guess my question to you guys would be, where do you get lost in having all this technology and you just forgot to ask the patient what's going on?
Well, actually, if you don't mind, I'd love to take that, Rahul. So this is why our rapid virtual clinic is so successful, because we don't even need to evaluate the patient more than just talking to them. I mean, they always tell us the answer. And I think one of the important points, we talk about size and stuff, but we also talk about those patients who say, Doc, I woke up this morning and I lost half my visual field on this side. I can't see it. And I've got flashing lights and floaters. And, oh, by the way, I'm like a -8, they hold their glasses. And, that also tells us information. That information is, get over here right now. You can't delay. And we have the retina specialist meet you. So, I mean, you're absolutely right. A lot of this stuff that I try to impart to people is, this is more like battlefield medicine a lot of times. You just need to know, does the patient need to come in or not right now? You don't need to count how many endothelial cells there are. So yeah, you said it perfectly. And if AI can help make that decision faster for us, or we're using things like IoT tools where if the parameters are exceeded for the eye care tonometer, the pressure is above a certain value, it alerts us, lets us know. Those are really important things for augmenting our practices.
Also, I think a last final point to this AI concept, I think, is going to be that you have probably 500,000 ophthalmologists in the world. You still have an 8 billion population. Every person wants a doctor for themselves. This is going to be the fact of how this is going to play out. And no matter what we say, we need AI for ourselves more than the patients need them for them. We need it to, kind of help us screen out the easy ones from the tough ones. And it's a numbers game, and that's how it's going to be at the end of the day. So I think if you look at the big picture, we're going to need this more than anybody else.
Well, thank you so much to the panel, and I just a tremendous conversation. This was so much fun to do with you all. So thank you for your time on this evening.
There was one question. It was, I think, off the topic, but it's an interesting one. Dick, since you're working with a lot of new companies, I think this is directed towards you, but I would like to know when will we have a truly neuroprotective agent rather than one that reduces pressure as a mainstay of treatment?
Neuroprotection for glaucoma has been a challenge, so I don't see anything in the short term. So,
okay, perfect. So you
I
have
do.
that.
I think there's a lot of tech coming out. I mean, there's a lot of stem cell treatment and gene therapy research being done right now. And I would think probably about 5 years or so. I mean, a lot of the pharmaceutical companies are investing in this angle, and it's already proving, at least in a lab, that it can do the job. So I mean, I don't think it's going to be too far off, actually, that we can use stem cells and gene therapy for this.
Ranya, when you say it can do the job, what define do the job?
Yeah, that's a good question. So actually, I just got back from Glaucoma 360 and they were doing this. They were showing this. They were using gene therapy and growing or, reinvigorating cells that were damaged by glaucoma. And they were then staining them with fluorescein. They were fluorescing when they were alive. And when they were giving off electrical impulses, it was checked with an ERG. That's when it was, it was shown that they were efficacious. So, I mean, it actually showed that they were generating action potentials and, and data from those neurons. So it was pretty interesting stuff.
Perfect.
You're optimistic on your timeline.
I'm always like that, Dick, sorry. But that's why this was a good discussion, I think, just to see everyone.
We've left so much for the future rising stars here. We can get into gene therapy, stem cell, oculomics, genomics. I mean, there's so much to discuss here. So, yeah, and I think we can deep dive in any
altogether.
But before we move on to the future ophthalmologists, let's also call it a session here because we really have run out of time. But it's been an absolutely stunning session. More importantly, Rahul, you spoke a lot about same-day bilateral cataract surgery. You brought about reimbursements, which was one of the mainstay problems. Even though in our minds in front, we always think about the safety element, that this is a very, very important discussion as well. So you brought about that, and Dick, to your point, you just threw it out of the park when you said that 10 years later, people are just going to laugh at us.
Yeah.
The kind of ophthalmology we practice, both in same-day bilateral cataract as well as dropless cataract. So yeah, I think those two elements were big. Virtual medicine, its future, what is going to happen, the ups and downs, how we've seen it in the pandemic, and whether it has a space in the future is still questioned and open for debate. Artificial intelligence, really, you spoke a lot about the true potential of where it could be, what it's really doing, and what it can do. So I think there's a lot to do, and I think a lot of the industry partners who are watching this must start, gearing up to, solving these issues. These are the big issues that really need to be solved and help the ophthalmologists, not just in specific countries, but across the world. There are lots of areas where healthcare is just zero, so that can really kickstart a big wave, and then that's one of the big ways of looking at this. Emerging trends, you've picked on absolutely spot on topics, Rahul, and really bring us to in the front. We've actually seen a beautiful rise of a star today, so fantastic.
Yeah.
Thank you so much, guys, for patiently listening. And this whole episode will be available on our website, risingeyestars.com. Don't forget Instagram, Facebook of our Rising Eye Stars. Please follow us. We'll be sending out some of this educational tips and pearls from this episode as well, which will be cut down to size only to educate people, as attention span in this webinitis era has become less than 45 seconds. Okay.
Well done, you guys. Well done, Rahul. Great job.
Thank you so much.
Don,
and
it was a pleasure.
Thank you, everyone. Thank you so much.
Thank you.